I've been on planet Earth for almost 64 years now, and I've done a lot of embarrassing things in my life, all of which I try my best not to repeat. But sadly, there's at least one embarrassing thing that I still do at least every couple months or so, and that is fall while going upstairs. How on earth does that happen? Well, why do I fall while going up some stairs? Well, it's usually because I'm not looking where I'm going. Maybe I'm in a hurry, distracted by something, and just simply not paying attention. So I miss a step and get tripped up and stumble and fall forward. And regardless of the reason, it's always embarrassing and sometimes even painful. Right now, I know what you're thinking. Marvin, what on earth does this have to do with Medicare? Well, let me explain. Right now, we're quickly approaching the time of year that matters the most for everyone that's on Medicare. It's called the Medicare Annual Enrollment Period, October 15th through December 7th. And it's the time of year when you do not want to miss a single step. You do not want to be distracted. You do not want to get in a hurry. You must pay attention. Because if you miss a step and stumble, it could be not only embarrassing, but also financially painful. In this video, I'm going to show you the 3 critical steps that you must take before October 15th and the 3 critical steps that you must take after October 15th. So please pay attention. I don't want you to miss a single step. All right, so let's look at step number 1 that you have to take, folks, before October 15th, and that's this, and that is that you must look at your ANOC. Now, some of you probably already have, others of you, I want to make sure though. The ANOC actually stands for Annual Notice of Change. So whenever you're on a Medicare Advantage plan or a prescription drug plan, you are on an annual plan. And so the company has the right to be able to change anything they want to for the coming year. And so they have to disclose all the changes they're going to make. So they mail that to you typically sometime mid-September or so. And if you don't have it or you didn't get it, just call the number on the back of your insurance card and let them know that you're looking for your ANOC, because you need to go through the ANOC for sure. So let's talk about the details in the ANOC that really are going to matter for you. Number 1, this is all about the plan that you're on. First off, is the plan still available? This year we're seeing anywhere from about 10 to 20% of Medicare Advantage plans being canceled, and about 20 to 30% of all drug plans being canceled. Okay, so that's the first question. Is your plan still available? Was it canceled? Or was it crosswalked? That means that there's a plan very similar to your plan. It's not the identical one, but they crosswalked it and enrolled you into a new plan, same company. All right, so that's the next question. So pay attention to the plan. And again, if the plan is available, still available, or it was crosswalked, we want to look at the details. So let's talk about that next. Number 2 here would be the premium. Many plans were either low or no premiums last year, but what we're seeing as a general rule is premiums increasing for 2025. Now again, some of them have not been real drastic. Drug plans have moved at most $35 a month, and then we're seeing some changes with premiums for Medicare Advantage as well. So again, make sure you pay attention to the premium for 2025, number 3, and then the prices. And this really is the critical issue, and that is, what is it going to cost you to be on the plan? Because if you're on a Medicare Advantage plan specifically, what you have is you have copays. And then you're also going to have some items that'll be co-insurance. Remember, a copay is a flat dollar amount. $10 copay to see a doctor, $50 copay to see a specialist, maybe $300 to have an MRI. But those are copays. Coinsurance would be a percentage of the bill. Normally, the plan pays 80%, you pay 20%, but you want to be sure you're familiar with the services where you're going to have to pay a coinsurance. So when it comes to copays, I would be looking at what it will cost you to have an MRI or a CAT scan, or if you had an outpatient surgery, cataract surgery, or knee replacement. What will it cost you to go to the hospital? That's very important. Usually they have a daily copay, somewhere between $350 to $400 a day, up to a certain limit. Your plan may stop at 5, may stop at 6, or may stop at 7 days, but once it's stopped, then the plan pays 100%. And then if you're ever rehospitalized again, then you would have to pay those daily copays up into the limit. So again, look at all the different prices being charged for the plan. What will it cost you if you go to a skilled nursing facility? So just look at those details so there's no shock with that. Number 5, the MOOP. The MOOP simply stands for the max out-of-pocket. So I'm going to talk just a little bit about this, because this is certainly a very interesting thing to be paying attention to, max out-of-pocket. And so what happens is Advantage plans are annual plans. They're structured with copays and coinsurance, but eventually those copays have to stop. The government requires the companies to put a limit on what you'll pay for that year. And so if you reach the maximum, which right now this year has been anywhere from about $3,000 to $5,000 on HMOs, PPOs anywhere from maybe $4,000 to $10,000. But the point is, if you ever do through your copays reach the max out of pocket, after that the plan pays 100%. But what happens is then those max out of pockets reset in January, and then again we're back to paying copays and coinsurance until we hit the max out of pocket. Now I want to clarify something. When you have an HMO plan, you only have one max out of pocket that's going to be published. And again, it could be $2,500, it could be $4,000, $4,500, something like that. But it's just one. Why? Because you have to stay within your network. So it's an in-network max out of pocket. All right, so now just so you know, if you're on an HMO plan, you can go out of the network if it's emergency or urgent care. But other than that, you're required to stay within the network. That's why there's one max out of pocket. But you'll notice on a PPO plan, you'll actually have two max out of pockets. You'll have an in-network and then out of network. And so the in-network could be, let's just call it $4,000. Out of network, it could be $8,000. Now, what I want to clarify here is that $8,000 is a combined in and out of network price. So it wouldn't be 4 plus 8, it would be 4 plus an additional 4 if you went out of your network. All right, so be paying attention, please, to the max out of pockets for 2025. We do anticipate they're going up over the 2024 ones. And then the perks. And the perks are going to be things like you'll have some type of a dental benefit typically, maybe some vision benefit or a vision allowance, probably have maybe the over-the-counter benefit. You could have a gym membership. So the point is you have a variety of things. Could have hearing aids. These are some of the perks that the Advantage plans offer. And what I'm encouraging you to do is know what the perks are and how to use them. Because everyone knows in this Medicare world that only about 20% of people even use the perks. 80% do not use them, sometimes because they're not either aware of them or they forget, or they're just it's not possible because of network limitations or restrictions. So be sure to pay attention to the perks, what they are, and how you're going to use them. So all these things will be revealed in your ANOC, so you look through that thoroughly. All right, that brings us then to step number 2 that I want you to do before we get into October the 15th, and that is this, and that is pay attention to your providers and your prescriptions. So let me clarify this a little bit. When it comes to providers, what I'm talking about would be your primary care physician. You want to make sure they're in network. Also, any specialist that you see on a regular basis. This could be a dermatologist or an OBGYN doc or a cardiologist, endocrinologist. So be sure they're going to be in the network. And then also hospital choices, okay? So if you have a hospitalization situation, you want to make sure that you can go to the hospital that you're comfortable with. So again, we're looking at the different providers. If you happen to have durable medical equipment, a CPAP machine, oxygen equipment, a scooter, wheelchairs, walkers, those kinds of things, we have durable medical equipment providers that are under contract with the Medicare Advantage plan. So be sure to be paying attention to that. Okay, so again, what are we trying to do? We're trying to make sure that our providers are in the network. Now, I do want you to know this year as we move into 2025, there have been whole hospital groups, doctor groups that are actually dropping Advantage plans. So just because they were in 2024 doesn't mean they'll be in network in 2025. Now, they should have notified you and the plan should have but again, you want to double check on that. So we want to make sure they're in network. The second thing we're going to talk about are your prescriptions. So the majority of you that are watching this are on Advantage plans. You have what is called an MAPD plan, MAPD. MA stands for Medicare Advantage, which refers to all the inpatient and outpatient care. And then you have a Part D plan that is actually embedded. It's included as part of the plan. And so we want to make sure that your prescriptions are covered by the plan. We're seeing a lot of changes going into 2025 with drug plans. Formularies are changing, so don't assume just because a medication you're on right now that's covered in 2024 will be in 2025. And so again, they're supposed to notify you of medications that are leaving the formulary, no longer covered, but this is going to be on you. You want to be sure to make sure your prescriptions are going to be covered. I also, if it were me, I would also want to find out not just are they covered, but what pharmacies can I go to? we'll see changes for this as well. You may have a plan that, let's just say Walgreens was the preferred pharmacy, and next year Walgreens is going to be standard, or maybe this year it was Walmart, and next year it's going to be CVS. But pay attention to the pharmacy options, because if you go to a preferred pharmacy versus a standard pharmacy, you normally get better pricing. So we're always looking for a plan where your prescriptions can be filled at a place that would be preferred, because again, you're going to save, you can save some substantial money for that. So certainly be paying attention to that. Now, I do want to address those of you that have standalone drug plans, meaning you don't have a prescription drug with an advantage, because what you have is you have A and B, and you probably have a Medigap policy, probably a G or an N plan, and then you have a standalone Part D plan, okay? Part D, this is for your prescriptions that you self-administer. So you want to do the very same thing, because those plans are really changing. In fact, we're seeing a lot of them this year. The premiums being increasing, formulary is being smaller. Again, preferred and standard pharmacies changing. So be sure to look at your ANOC when it comes to the details on your standalone prescription drug plan. All right, now I do want to clarify something that is really the biggest change that we're seeing for 2025, and that is going to be your out-of-pocket expenses for prescriptions in 2025. Let me explain. Hey, if you found this video helpful and you want to see more Medicare information just like it, then go below, right below the video, and you can give us the thumbs up as well as subscribe to our channel. And every time I put a new video, which is about 2 every week, you'll be notified of that video, and others just like you who need this vital information will get it as well. All right, so we put together this particular grid that will actually show you how drug plans are going to be structured for 2025. They changed the system really drastically from 2023 and 2024. As we get in 2025, this is exactly the way drug plans are going to be priced and structured for copay. So let me explain. And so I actually want to begin down here at the bottom, because when we're enrolled into a prescription drug plan, there's actually 4 potential payers of those prescription drugs, and that changes for sure. And so the payers would be you, the patient, meaning you enrolled into a plan and you're the patient. You're going to have certainly an out-of-pocket expense. And then the Part D plan, this is why it's such a big deal, because they are also going to be paying for some of the cost of your medications. Medicare sometimes will, and the manufacturer also participates. But my whole point is these are the different payers. So whenever we get a prescription, what we're trying to do is we're trying to show you we're going to get to 100% with a combination of these, or maybe just one of these. And so it's critical to understand how this structure has been organized by Medicare. So let's go up here to the phases. This year we have 3 phases. Now 2024, we had 4 phases, and one of those phases was called the coverage gap or the donut hole, and that is now eliminated in 2025. All right, so beginning January 1, we'll no longer have to deal with the donut hole. But so now we have 3 phases, and the first phase is called the deductible phase. Now this year that deductible is $590. Now I want to clarify something for those of you that watch me on a regular basis. We've been talking about the changes for several months now, and originally when Medicare proposed everything for 2025, they told us the deductible is actually going to be $540, and that was published, that's what was revealed. But then when all the bids started coming in from the Part D providers and there was some pushback on some of the new rules, Medicare agreed to raise the deductible to $590. So if had seen me say $540, that's why I did that. Now we know it is $590 when it comes to deductible. Now, that deductible phase means this, that any medications that you get in this phase, you are 100% responsible, whether it's generic or a brand name medication, whatever the cost, that would be the reduced Medicare cost, then that's what you're going to have to pay. And that would be up to that deductible $590. Now the truth is, many of you are on meds that are very, very low cost. You'll never even get to $590. So if you don't get to the deductible, then you'll just simply stay in this phase 1 all year long. You do not move on. Okay, but if we happen to be on lots of meds or maybe on some expensive meds, then we could meet that $590. You could do that the first month or 3rd or 4th month. But if we ever reach that $590 out of pocket, we've paid 100% of the cost of the meds, then we'd be done in stage 1, and we go to stage 2. All right, now I do want to clarify something about the deductible. The deductible on a plan can never be higher than the maximum that Medicare sets, so never be beyond $590, but it could also be less than that, reduced from $590 by the plan, or they could even bring it down to zero. And typically when you see a prescription drug plan that has a higher premium, it's almost always going to have a reduced or a zero deductible on it. But if I have a deductible, got to meet it. If I don't, then I'd go to phase 2. This is called initial coverage. We have this in 2024. It's still going to be around in 2025. So here's what I want you to see though. Again, we're always trying to get to 100% of the cost of the reduced cost for Medicare medications. So in this stage, now what happens, you're only responsible for 25% of the cost. Here, you had all of it. Here, 25%. Doesn't matter whether it's generic medication or a brand name, you'll pay 25%. The balance of that 75%, remember our different payers, what's going to happen, if you're taking a generic drug, that drug plan that you selected is going to pay 75% of the cost. You pay 25%. If it's a brand name medication, the drug plan pays 65%, and the manufacturer has to pay 10% of that medication, meaning they'll discount it 10%. All right? So what's going to happen though, and this is the big change, while I'm in this particular phase here, Medicare has now set a spending cap. The most you can spend throughout the year. This year was $3,350. Next year and thereafter, it's $2,000 for the whole year. And that $2,000 spending cap includes my deductible if I had to pay that. All right? And so now we spend up to $2,000. So what we're saying is 100% up to $590 and 25% up to the total of $2,000 out of pocket. Now, I want to clarify something about the $2,000. Sometimes people are on very expensive medication, and that $2,000 responsibility could be the first month. And so what happens is Medicare realizes that could be challenging for some people, so they'll take that $2,000. You have to enroll into a program that will actually smooth it out and spread that $2,000 out throughout the year. You have to enroll into the plan, and then they'll make sure that the impact of that $2,000 then is not 1 month. It could be spread out for the remaining months in the year. So be sure to enroll in that plan if this becomes an issue, and you'd actually enroll in that smoothing out provision through the prescription drug plan that you select. All right, let's go on now to number 3. So once we've met the $2,000 out of pocket, now we go to what's called catastrophic. And again, we've had this year, and your responsibility is zero. Why? Because you've already hit your cap. So how do we get to 100%? Well, that drug plan that you're on is going to pay 60% of the retail cost, and then Medicare pays 40%. If it's a brand name medication, drug plan still pays the same, 60%, but the manufacturer must discount 20% and then Medicare pays 20%. All right, so that's how we get to our 100%. And I share all that with you because you'll see in your annual notice of change that this is exactly how they're going to describe drug plans moving forward. So I just want to give you some further details of that, so hopefully that's helpful. All right, that now brings us then to step number 3, and what I want you to do is look at your health. Well, why would I say that? Well, because this is the time of year where many people are going to be switching plans, and sometimes your health is going to matter. So let me kind of clarify this. If you're presently on an Advantage plan and you're just simply going to move to another Advantage plan, what happens, you can do that from October 15th through December the 7th. Okay, and your new plan that you select will go into effect January 1. That's going to happen for many of you. If you don't do it then, you still have one more opportunity. As long as I'm on an Advantage plan January 1, I have all the way through January 1 through March 31 of each year where I can move, again, Advantage to Advantage. Now, I got to be on Advantage plan January 1, but now I have 3 more months that I can make a move. So if I don't make a move here, I still have an opportunity, or if I made a move here and I find out I'm not happy with that decision, then I can reverse that the first quarter of the year. And whenever we make a decision here to get into a new plan, we enroll in January, our new plan starts in February. Enroll February, it'll start in March, do the switch in March, they'll start you in April, okay? And so the Advantage to Advantage, when you make that kind of switch, folks, there's no underwriting required, okay? Which means as long as you're enrolled in A and B, and that Advantage plan is in your service area, the area where you live, then you can make that switch. No health questions, no issues whatsoever. The Advantage plan will approve that application. So that's one way we can switch. Now, there could be a possibility that some of you right now want to make a different kind of switch, and that is this. You are on a supplemental plan right now. You may be on an F plan, a G, or an N plan, and you actually want to leave the supplemental plan and you would like to take an Advantage plan. Okay, you want to enroll in one of those. But again, the only time you can do that is right here. You have to make that move October 15th to December 7th to move from Sup to Advantage. The January 1 to March 31 would not be an option for you at all. And so again, if you say, I want to make that switch, you make it here, and you can get onto an Advantage plan, again, as long as you're enrolled in A and B. That plan's available in your service area, and again, there will be no underwriting involved whatsoever. Okay, now there's another way in which people switch. This is number 3, and that's those of you that are on Advantage and you want to go to a supplemental plan. Okay, and let's just suppose here, theoretically, you've been on that Advantage plan for a year, or 2 or 3 or 4 or 5 years plus. They've been out since 2003, so about 20 years now, but you've been on that plan for a period of time. Beyond a year, and so you're on the Advantage, but you would like to move to a supplemental plan. All right, now that process is different. So what's going to happen now is we are going to have to go through underwriting to make that switch. Now, you would not have to if you live in New York, Connecticut, Vermont, Maine, or Massachusetts. They have some different rules. New York, Connecticut, Vermont, Maine, Massachusetts. But everywhere else, including the District of Columbia, you're going to have to go through the underwriting process. So that's why I'm saying you've looked at your ANOC, you've looked at your providers, and you're saying, you know, I want to get off that Advantage plan. I want to go to the supplemental plan. That's why I'm saying here, look at your health now. Begin to evaluate, is this something that I can do? Am I healthy enough to go through underwriting? And so what I'm going to do just real quickly is I just want to go through, and I just pulled one company's application randomly, and I'm going to go through this because the process of going through underwriting means we have to ask you a series of health questions, all of which you have to say no to. We're going to check your medications you're taking now and what you've taken in the last 24 months, and we submit that information to the insurance company, and you go through underwriting, and they're not obligated, except in those 5 states, they're not obligated to approve your application. They can say, no, we don't like your pre-existing conditions. We don't like this about your health situation, so they can deny you. And again, you don't have to be perfectly healthy, ready to run a marathon, but you got to be generally healthy. Okay, so I'm going to go through the questions that we would ask you. And again, this is a sample, but here's what it says. Health questions. If any health questions are answered yes in this section, the applicant will not qualify for the insurance with us. Okay, and each company has a few different questions, but there's a lot of similarities. So let's get going. Question number 1, are you dependent upon a wheelchair or any motorized mobility device? If you say yes, you're declined. Number 2, do any of these situations apply to you? Are you currently hospitalized, confined to a bed, in a nursing facility, assisted living facility, receiving home health care or physical therapy? If you say yes, again, you're declined. Number 3, at any time, meaning any time in your life, have you been medically diagnosed with, treated for, or had surgery for any of the following? So again, any of these that you say yes to, you're going to be denied. Congestive heart failure, unoperated aneurysm, defibrillator, leukemia, lymphoma, multiple myeloma, cirrhosis of the liver, Parkinson's disease, Lou Gehrig's disease, Alzheimer's, dementia, multiple sclerosis, muscular dystrophy, cerebral palsy, chronic kidney disease, kidney failure, kidney disease requiring dialysis, renal insufficiency, Addison's disease, any condition requiring a bone marrow transplant or a stem cell transplant, any condition requiring an organ transplant, AIDS, age-related complex, or HIV. Number 4, have you been medically diagnosed or treated by a member of the medical professional for diabetes? Now, carriers vary here, but this particular carrier would still approve you if you're a type 2, meaning you don't use insulin. But they're going to ask you, that requires the use of insulin. So this company says use insulin, we're not going to approve you. Again, if you're just taking oral meds, metformin, those kind of things, you could still be subject to approval. All right? And so diabetes, have you had diabetes with complications, including retinopathy, neuropathy, vascular arterial disease, or heart artery blockage? If those go along with your diabetes, you're declined. A history of heart attack or stroke at any time, you'd be declined. Treated with medications that have been changed or adjusted in the past 12 months because of uncontrolled blood sugar. If so, you'd be declined. Within the past 36 months. So as I read this list, these conditions could have been 4 years ago, 5 years ago. It's all fine. But in the last 36 months, they're looking back saying this: been medically diagnosed with, treated for, had surgery for alcoholism or drug abuse, cardiomyopathy, atrial fibrillation, anemia requiring blood transfusions or any other blood disorder, internal cancer, last 36 months, melanoma, Hodgkin's, hepatitis, disorder of the pancreas. So if you said yes to any of those, again, decline. Now they're going back 24 months. So if it's prior to that, doesn't matter. Last 24 months, been medically diagnosed with, treated for, had surgery for an enlarged heart, stroke, mini stroke, peripheral vascular disease, arterial disease, neuropathy, amputation caused by disease, myasthenia gravis, excuse me, systemic lupus, connective tissue disorder, osteoporosis with fractures. Sometimes osteoporosis is fine. Again, no fractures, of course. Paget's disease, arthritis that restricts mobility, typically rheumatoid, or the activities of daily living. Any lung or respiratory disorder that requires the use of a nebulizer or oxygen or 3 or more medications for lung or respiratory disorder. Again, you'd be declined. Any lung or respiratory disorder and currently using tobacco products, you'd be declined. Now, last 12 months, I'm almost done. Last 12 months, been advised by a medical professional, now listen to this one, to have treatment, further evaluation, diagnostic testing, or surgery that has not been performed. Meaning doc says you need a knee replacement, but you haven't done it, you'd be declined. Any tests that have pending results, you want to wait till those results come in before you apply for a Medicare supplemental plan. Last 12 months, been medically diagnosed with or treated for, had surgery for a heart attack, artery blockage, heart valve disorder, so like stent implants, those kind of things. In the last 12 months, you'd be declined. Last 12 months, been medically diagnosed with wet macular degeneration or have taken or are currently receiving injections. Again, declined. Last 12 months, had a pacemaker implanted. They decline you. A man, a PSA blood test greater than 4.5. If you're under 70, if your PSA is above that, they would deny you. If you're if you're under 70, 4.5 is fine, but above that, they would decline you. If you're above 70 years old, you can get up to 6.5 on your PSA, and they would still approve you as long as you've never had prostate cancer. Have you had a seizure in the last 12 months? If so, you're declined. And then they ask about your last blood pressure reading as well. And so then we would take your medications. And again, all this information is given to the underwriter. And so what are we looking for? We're looking for them to say, yes, we will approve you. So what would happen if you're on this Advantage plan, that would still be your plan through December 31. And then your supplemental plan would go into effect 1/1 of 2025. And then when we make this switch, we also select a prescription drug plan for you, a standalone drug plan. And when we do that enrollment, what that does is that kicks out your Advantage plan automatically on 12/31, and your new plan goes into effect January 1st. So that's why I'm saying to you, look at your health so we'll know what our options are. So if you could not pass underwriting, then we know what? This is the kind of move we're going to have to make, Advantage to Advantage. Or if you're on a SUP, again, if you want to move, regardless of your health, you can move to an Advantage plan at this time of the year as well. Hey, if you come to a place where you know you're going to have to make some Medicare decisions pretty soon, the best way to do that is to click up here in this right-hand corner, and you'll have an opportunity to be able to book a call with one of our Medicare guides. All the guides around here I have personally trained, and they truly are professional. They'll answer your questions, and they'll show you different Medicare options to make sure that you're confident in the decision that you make. All right, so that's the 3 steps before October 15th. Now let's talk about the 3 steps that are critical after October the 15th. The first step is this: look at your plan options. So we know what we've been on. Now let's see if we are going to make a switch, what are we going to look at? So first off, remember when it comes to Advantage plans, folks, there are 2 types of plans. There are HMOs and there are PPOs. So when you look at these plan options, be sure that you know going into it, HMOs are almost more attractive financially. Lower copays, more benefits, additional benefits, lower max out of pocket. So they really make those attractive, but you got to make sure that you know that you're going to have to stay in your network, because if you go out of the network, it's not going to be covered by the plan unless it's emergency or urgent care. Okay, so know that. So some of you may be comfortable with that. Others of you may be on an HMO and say, hey, I want to go to a PPO. Now your PPOs are going to cost you a little bit more as far as copays, max out of pockets, but at least you have the option to go out of the network if you would ever need to do that. All right, and so if you decided I'm staying in the Advantage plan, that's what you want. You're going to pay attention to that. We're checking providers. So any plan you like, then we got to make sure our providers are covered and our prescriptions are also included within the formulary. Okay, and I do want to mention something about prescriptions right now that I failed to talk about earlier, and that's this. When you have a prescription drug plan, whether it's standalone or it's embedded within the Advantage, they do have some management tools that they utilize and will utilize. So you got to be familiar with this. So sometimes drug plans have what they call a quantity limit. So you may be on a medication that's addictive or expensive, and it may cover it, but it says QL. And that means there's only so many pills in the bottle, maybe a 30-day fill or a 90-day fill, and that's it. You got to live with that, so be paying attention to that. There also are some medications that will have an ST beside it. That's called step therapy. And so if it says ST, it means that there are some generic equivalent or generic alternatives. The step therapy medication is normally a brand name. And so what you have to do is you have to try the lower cost generic medications. And then if those don't work, or your doctor says, we tried that doesn't work, then they will step you up and fill the brand name. But if you never have tried those lower cost meds, you're going to have to do that. And then one more thing I want to talk about, and that's called PA. Sometimes a medication has a PA beside it, and this means prior authorization. And that means this is an expensive medication or addictive, and before the plan can fill the medication, you or your doctor, you have to fill out some additional paperwork. And if once that's submitted, then the plan will look at that, and they probably will approve it, but they don't have to. It's a prior authorization. And so if you had a prior authorization medication in 2024 and you go into 2025, you'll probably have to go through that process again, or a formulary exception. They may approve it for 2024, but you have to go through that process again. So be sure to know about that as well. Okay, so enough of that. Let's make sure we're clear on those plans. Now, as far as plan options, let's say you're on that Advantage plan and you're decided that you want to go to a supplemental plan. Okay, and so what you're going to do is, what will those options be? Now, I can tell you the top 3 plans right now are F, G, and N. Very few people are getting Fs, but it's still a possibility. But you had to start Medicare before 1/1/2020 to be able to get an F plan today, because anyone who starts Medicare after 1/1/2020, F plan is not going to be an option. F was a full coverage plan, and they've grandfathered everyone in who started Medicare before 1/1/2020 to be eligible for Fs, but beyond that, no. And so if you're born after 1/1/55 and you started Medicare after 1/1/2020, then these are your top 2 plans today. Would be a G or an N plan. I'm not going to go into all the details other than to say the G plan covers 5 of the 6 Medicare gaps, and the N plan pays 4 of the 6 gaps, plus you have a doctor copay and an emergency room copay. But these are your top plans, okay? And they're both very good. I wouldn't say one's better than the other. It just depends on what you're looking for. So if someone's looking for the most comprehensive coverage they can have, then they would definitely select the G plan, because the only gap you have to pay is the B deductible once a year, and that's it. That's all you're responsible for. The other 5 or 6 gaps are covered. The B deductible this year is $240 for the whole year. I don't know what it'll be in 2025, but again, you'd be responsible for that once a year. So the N plan, what it does, it covers 4 of the 6 gaps. It will not cover the B deductible, just like this one. So you would have to pay the B deductible, that's the Medicare Part B deductible, and you would have excess charges. That's when a doctor adds 15% to the bill. Now that doesn't happen often. Less than 5% of doctors even do this. It will happen occasionally, but less than 5% chance. But if you had an N plan and you had excess charges, you would have to pay that. The G would pay it for you. And so my point is, G is the most comprehensive, but N is still a wonderful, wonderful option. There are some states, 8 states actually, where excess can't be charged. So it doesn't happen a lot anyways. And then on the end plan, you have some copays. You go to the doctor, you could have a copay up to $20, emergency room up to $50. So again, very minimal. And usually the difference in premium in most states is about $35 to $40 a month. Some states more. For sure, but the point is, you just have to decide, is that savings monthly worth taking on a little bit extra risk? And for some people, they say, yes, I'll take the savings. Others say, now the $35 or $40 is not going to make or break me. I'll go ahead and take the most comprehensive. That would be the G plan, but they're both wonderful, wonderful options. So that's what I want you to look at. Now, secondly, what you're looking at is what's it going to cost you to be on the plan, because they're going to charge you a monthly premium. Now, let me tell you my view on this. Okay, what I would do is this. When I select a plan, I am looking for a plan that has as large a block or group as possible, which means I look at companies that have the greatest amount of market share in that region or that state, wherever you live. I'm looking for a large market share. Why? Because the more policy holders in that group, the less price increases we're going to see, or the less drastic price increase we're going to see. No matter where you live, no matter how your plan is rated, whether it's attained age, issue age, community rated, they all go up in price. And so the key is finding a company that has a good market share. Well, that's why we like national carriers. Why? Because the larger the block, more than likely will be the more stable the rates. I describe it kind of silly, but it's true. I describe the block kind of like being in a canoe and you're out in the ocean. Okay, small boat, big body of water, you're going to feel every single wave. But if you're in a cruise ship in the middle of the ocean, sometimes you ain't know you're in the water, right? You're not going to feel the impact of those waves. So when I have a larger group, the risk of healthcare costs is spread out to more people. If I get in here and I'm over here in a smaller group, and that group has a lot of cancer, a lot of hip replacements, knee replacements or something, you're going to feel the pain of that. So again, we're looking for a larger group, a company that has a good sized market share wherever you are. So the whole point is you want to be sure to take the time to look at your plan options, decide what's going to be your best move. All right, that brings us then to step number 2. And again, we're talking about after October 15th, look at your budget. In other words, can you afford this? Now, some of you would say, I don't think I can really afford a premium for a Medicare supplemental plan. Because remember, that's the way it works. So if I have a supplemental plan, I've got A and B, I got to pay my B premium, that's $174.70. And then if I get that G plan or that N plan, that's going to range anywhere from $100 to probably $150 on a monthly basis. Okay, and by the way, there could be some states a little more, a little less. I'm just trying to share with you. That's what you have. And then we have a drug plan. And some of those drug plans are zero, and they could be upwards to $50. So the whole point is we're looking here at about, what would that be? About $375 on a monthly basis. Now, I'm not going to be out of pocket very much because I paid a premium, got rid of all my out-of-pocket liability almost on my supplemental plan, but I got to be able to afford that. And some of you say, hey, I can do that. And again, when you do that, I would call that Cadillac insurance. Those are wonderful, wonderful plans for sure, but some people say I can't do that. And so what you may need to do is you may need to get one of these Medicare Advantage plans. Okay. Now, with the Advantage, I still got to pay my Part B premium. And by the way, when I say $174.70, I'm shooting this video in 2024, September. I don't know what's going to be in 2025, but whatever it is, that's what we pay. If you're high income, then you pay more actually, but that $174.70 comes out of your Social Security check, or they'll bill you quarterly, or they'll do a bank draft with you if you'd like. But we got to pay Medicare the Part B premium. A is free for most people, no premium, but B has a cost. Then we got this C plan, this Advantage plan. Now this year the average premium is right around $20. I suspect that's going to go up. There'll still probably be some plans that have a zero premium, but again, we have that. And then what happens is then we pay as we go. Pay as you go. Over here, I paid a premium, and I didn't pay much beyond that. Over here, I pay as I go. Go to the hospital, $300 or $400 a day. See a specialist, $50 copay. There's just certain copays you'll pay on those plans, so you pay as you go. So we don't know what we're going to spend, but you still need to look at your budget and decide, are you comfortable with this? So the way Advantage plans work, as I talked about earlier, they set a max out of pocket for the year. It could be as low as $3,000 or $4,000. It could be as high as $8,000 to $10,000. And I encourage people, if you cannot afford that max out of pocket, if you got cancer and a serious illness, then what I would do is I'd buy some type of an indemnity plan or a copay protection plan to cover if you went to the hospital, or to cover some of your cancer expenses. Those are very, very low cost. And so I definitely would look at your budget. So if you cannot afford this, and we're going to go this way, be sure you can afford that annual max out of pocket because you're responsible for it every year. All right, that brings us to our final step that we don't want you to miss, and that is this: to be sure to look to a trusted advisor. Someone that will care about you enough to give you all the facts, explain all your options, but really will be very thorough with you. That's what we call a trusted advisor. And again, we can't put people on Advantage plans or drug plans until after the 15th of October. Of course, supplemental plans really anytime, but look to a trusted advisor. So I thought this would be a good opportunity for me to show you what your options are as far as finding someone to help you. The first option you have is to use what we call a call center agent. Okay, I am not a huge fan of call center agents. I think it's fine to do business over the phone, online, all that kind of stuff, no problem. But a call center, this is where most of your ads are directing you to. 800 numbers, and they're direct you to what I call 1-800 dial an agent. And so when you call into a call center, you're going into a massive call center, usually multiple hundreds, sometimes thousands, where people are working there. They're agents. Sometimes they are competent, well-trained, but the majority of the time they're not. There's a lot of turnover in call centers, a lot of pressure. Call centers primarily are pushing Advantage plans. They don't train their people on even the kind of the ins and outs of supplement plans and the different options. They're really just pushing Advantage plans because they pay a higher commission. And so, but your experience is going to vary because every time you call in, you get a different agent. That agent could be in the business for a year, could be in the business for 1 month. You have no idea what you're going to get. So again, I'm not a real fan of that. Number two, you can use what's called a company captive agent. A captive agent. Now, a captive agent just simply means this is an agent that works for one company. They're captive to the company. They work for ABC Insurance Company. They work for XYZ Insurance Company. They're an employee of the company. Now, again, a lot of them are trained well. I know lots of them for sure. The only issue is when you do business with a captive agent, you're only getting exposed to one company's portfolio of products, which is very limited. One size does not fit all in the Medicare business, and so captives are limited in what they're going to show you. And I can assure you every single captive agent is always going to say they have the best. They're not going to encourage you to shop around and look around. They're going to say we have the best, and that's just simply not true. And so that's why we and others like us have chosen the third option that you have, and that is with independent brokers. We are that. There's others like us. And so as a broker, we are not captive to any one company. We write for most of them, okay? But we're not captive to them. We write for multiple carriers. Who we're captive to is our clients, the people that we're trying to help them with their Medicare planning and get them on the right plan that's going to fit them. And that varies area to area and person to person for sure, but that's what independent brokers do. But here's what I'm trying to teach you and want to close with is this. No matter who you go with, a captive, a call center, a broker, it doesn't matter. Okay, here's what happens. The price is all the same, okay? Why? Because we don't set the price as the companies do. So the price should always be the same. So whether you go 1, 2, or 3, you're not going to spend more money. If you go 1, 2, or 3, you're not going to save any money. Okay, it's all going to be the same price as far as the premiums go because the company set those. But here's what will differ, and then you will definitely have a different level of service. I can assure you, if you go with a call center agent, 99 times out of 100, you'll get a new agent every time you call in, and you write a plan, and you'll never hear from them again because that's just not the way they do business. They write plans. They really don't service people. So you use a call center and you have a service problem, claim problem or whatever, you'll call in the 800 number and you're going to be transferred overseas, some foreign call center. It's going to be in the Philippines or India or China or someplace like that. And sometimes they're hard to understand, and sometimes I think they don't even understand Medicare. But that's the experience you're going to get here almost always. Now, when it comes to service of captive, it's better, but again, you're limited with your options and choices. And so what we have chosen to do as independent brokers, we have our own customer service department. So we don't just simply write a plan. We are committed to you for the rest of your life. And so we'll service you. You have a claim problem, you have any issue that come up, we get involved. You can call us direct. It's not going to be transferred overseas. It's going in right into our home office where English is our first language and we understand Medicare. So we tell our clients, you only have to call the carrier, call us. We're the agent of record and we will help you with that. All right. And so the whole point is find someone that you can trust. Someone with an integrity that will take the time to be thorough with you, explain all your options, not push a product or a company, but rather explain to you what is available to you, and then you make that choice. And we'd be delighted to be that trusted advisor.